Today's my topic is segmental spinal for floating shoulder, a novel approach. We'll just go through one case report. We have a 35-year-old male. He has a polytrauma with the fracture ribs, second to ninth fractures on the right side, with the fracture clavicle right side and a fracture scapula right side. So when there is a fracture scapula and the fracture clavicle, although it's a rare, it is known as a floating shoulder. So basically, we have to get this patient operated for clavicle and as well as scapula. So for clavicle, we can go for the superficial cervical block and the surgery can be done. But for the scapula, there is no regional block possible. So the surgery can be best done under general anesthesia definitely. If we put a patient under general anesthesia, then the fracture scapula can be addressed. Now, the no regional block is possible at this site of fracture scapula. The problem with the paravertebral block, it can be definitely used, but the problem with this block is mostly it is used as a post-operative pain relief and not for the anesthesia per se. Mostly it's an inadequate block and used for the pain relief in the most cases. Now this is the X-ray showing, you can see there is a fracture scapula and the fracture clavicle. This is a 3D CD image and you can see the fracture scapula here. So the plan of anesthesia was general anesthesia, which is a conventional approach. Now, and another one is a paravertebral block with the superficial cervical plexus block. Another problem with the paravertebral block is the problem with the LA toxicity because large volume is used in multiple pricks and multiple levels. So LA toxicity should be the disadvantage of this paravertebral block. Now the another option and the new approach, we can call it as a novel approach also, is a segmental spinal anesthesia. So my plan was to give this patient the segmental spinal anesthesia for fracture scapula, blocking the level of C7 to T7 so that the fracture scapula can be done under block levels and anesthesia of these dermatomes, as well as the superficial cervical plexus block for fracture clavicle. So we go for the segmentals. We plan for the segmental spinal for fracture scapula and superficial cervical plexus block for the fracture clavicle. The procedure was a simple, but the position of the patient before giving a segmental spinal was a sitting. Then the level of segmental spinal, the level at which we gave it is a T4. Needle use, we used a 27 gauge Twinkies needle. The drug I use is isobaric levobupropion, which is a 1.2 ml with the 5 mics of dexmedetomidine as an additive. So thereafter, I received the level of C7 to T7. This is the skin marking I have made on the patient. So the most prominent vertebra you can see this C7 and the blade of the scapula where it ends, it's a T7. So now this is after giving segmental spinal to this patient. So we checked for the anesthesia. So surgery started. So this was the surgical huge incision and on the right side you can see the post-operative suture line. So what adverse event I noted in this case was there was after giving a segmental spinal and positioning of the patient, I just noticed there was a brief episode of bradycardia with the heart rate going down to the 40 to 50, not less than that, not less than 40. But it got relieved on the injection glycopyrrolate 0.2 milligram IV. There was no episode of hypotension, no evidence of high spinal anesthesia or any respiratory depression. On the recovery mode, the patient was recovered well with the sensory effect almost lasted for the 7 hours, maybe due to the dexmedetomidine as we use as additive. He was almost pain relieved for almost 36 hours with a VAS score of almost 1 to 2 per 10. So there was no need to add any additional opioid or the NSAIDs in the post-operative period for almost 36 hours. Now moving on to the just brief regarding the segmental spinal anesthesia. It is also synonymously used with the term that is thoracic spinal. So what is the definition? The definition is blocking of the required dermatome essential for the proposed surgical procedure with a very low volume of LA drugs by giving the spinal ear targeted nerve. In this case, we just target the dermatomes where the surgical incision is there and we just give the local anesthetic that is with a very low volume to just target that nerve that are essential during a surgical anesthesia. So often necessitate the dural puncture at the high lumbar or the thoracic level. So in case of segmental spinal anesthesia, like conventional spinal anesthesia, we give our drug at the level of L3, L4, at most just L3 or L4 or L4, L5. But in case of segmental spinal anesthesia, we give spinal anesthesia at the level of high lumbar, like L1, and the thoracic level, like uppermost level is T4. And in this case, we use very low volumes. And when we use very low volume, that is a case where patient has a true segmental spinal block. So brief history, in 1909, Thomas Geneco, he coined the term the general spinal anesthesia for surgeries or head, neck, face, where the spinal was used instead of general anesthesia, where he gave the spinal at the T1 and T2 level, and the patient was operated on the head, neck, and thorax. So that time he coined the term general spinal anesthesia. So thereafter, it was again reviewed and re-opinion in 2006 by the Andre van Zundert, who gave the spinal at the T10 level for the lap chole in a patient with the severe COPD, who was very high risk for the general anesthesia, and he has to undergo lap chole. He gave the spinal at the level of T10 for a conducting lap chole. Acceptance and the popularity, COVID-19 pandemic, where the general anesthesia was considered to be a risk factor for whole OT team, as well as anesthesiologists, as well as surgeon, due to the spread of COVID-19. So that time it really gained the popularity due to its non-interference with the airway. So now, and basically this is a trending regional anesthesia technique in modern day anesthesia. Mostly people are very concerned about the segmental spinal. Here it's a solution for that. Basically, we are more worried about the injuring needle trauma to the thoracic spine, because our spinal cord ends at the L1 level in the adults. But the solution and the explanation to this says that if you observe this space, then you can see that in the mid thoracic level, the distance between posterior dura and spinal cord is more. So injury to the spinal cord during thoracic segmental spinal is minimal when the patient is sitting. Now this is the transverse and pictorial depiction of the spinal cord at different level when it was just transected in between. So this is a thoracic level where we are giving the spinal. So there is a distance is more here than the thoracolumbar, and this is the cauda equina. So it is safe if you give the higher level spinal, then getting the injury to the spinal cord is very minimal. So Lee R.A. et al. Found the distance between the posterior dura and spinal cord to be greater in all position at the mid thoracic level, more so in sitting and the lateral position. So he found out that on the MRI examination at the T2 level, the distance was 5.19 mm from posterior space. So at a T5, it was a 7.75, and at a T10, it was a 5.88 mm. So where our target is T4, T5 level, that place the distance between the posterior surface of the spinal cord and the dura is highest, that is 7.75 mm. So, and also the amount of CSF is less at the thoracic level due to the natural kyphosis of the human. So T7, T6, T5. So due to the low CSF volume, the low volume of drug is required to anesthetize these dermatomes. So what is the safety? As a few dermatome experience a sympathetic block, so there is a small reduction in the preload, and blood pressure is mostly stable in case of segmental spinal. So experience before the thoracic spinal is required, as it's a little tricky. Whosoever employing this technique, it's a little tricky one because of the inferior deviation of the just acute angle of the spinous processes of the thoracic vertebrae. So segmental spinal is mostly economical, and because of you don't require drugs for general anesthesia, endotracheal tube. So this is very economical. Immediately after the surgery or 1 or 2 hours of the surgery, the patient ambulation is possible. So it will reduce definitely your hospital stay. And so that's why we can say that the segmental spinal is very economical. So technique of thoracic segmental spinal anesthesia. The lower volumes, more the lower volumes you use, the true segmental block it will give to you. So only we anesthetize the dermatomes involved for the proposed surgery. What are the techniques, the modes of the segmental spinal? It can be a single shot segmental spinal, which will last for 90 to 120 minutes unless you add some additive to it. We may prolong it to more of the 180 minutes. Then it can be combined with the segmental spinal and epidural also. And you can give the single shot of segmental spinal and also put the epidural catheter on the higher side. And also one another option is continuous segmental spinal. You can just thread the catheter into the dura space, and you can just give the intermittent boluses with this segmental spinal catheter, also known as continuous segmental spinal anesthesia. But this is a little risky. And also you need to remove the catheter very early, and also take the, because the catheter is there, the chances of irritating the nerve roots are there. Before applying for the segmental spinal in your clinical practice, you should be thorough of this dermatome which are supplying to that specific area which is undergoing a surgery. Now, just a simple landmarks, we can see the vertebral prominence is C7. The root of spine, it indicates the level of T3. Inferior angle of scapula, it corresponds to the T7. Then the TL1 at the spinal cord ends. The rib margin and the 10 centimeter from midline, it's a L1 space. The superior aspect of the iliac crest is L4 and posterior superior iliac spine is S2. So if you do have the USG, it will definitely give the safety to the patient. Also, it will help you to just locate the midline as well as the exact location of the vertebral space. So now in USG, we use the counting up methods. That is, we just scan through 12th rib and we just measure the vertebra upwards. So you can go for the midline as well as paramedian, and you can use the quincase as well as Whitaker needle. So which drugs we can use in segmental spinal? They are isobaric, then hypobaric, hyperbaric, and and it can be a combination of both. So isobaric drugs are prepared in the lab chole, video assisted thoracoscopy, breast surgeries, superficial abdominal surgeries, major intra-abdominal surgeries, in particular in the morbidly ill or frail patients. So which are the advantages of isobaric drugs? Main advantage of isobaric drug is it's a non-position dependent. If the patient is sitting and you are giving him the isobaric drug, then you don't need to just place the patient supine, and thereafter you have to, if you want to put a catheter to the patient, you can just keep the patient sitting and put the epidural catheter. Then this is the advantage of isobaric drugs. But problem is that it has a propensity more for the sensory than the motor. And also there the hemodynamic stability is maintained in this patient because of the less sympathetic blockade. Though spinal can be given in the operative position. If we are not able to make the patient position lying down or the operating site upside, then we don't have to worry about that. We can keep the operating site up and give the spinal in that lateral position to the patient. Then spinal can be given before the putting epidural catheter, as I said. Disadvantage again, they are a less muscle relaxation, sensory more than motor, and the muscular male patient will require more drug. So what are the hypobaric drugs? So hypobaric drugs are, we know the CSF density is 1.0059 plus minus 0.002, and it can be used for the posterior spinal hemianesthesia in the prone position. If we have to use the posterior spinal hemianesthesia, we can give the patient the drug in the prone position also. So how it can be prepared, hypobaric drugs? It can be prepared by mixing an isobaric drug with the sterile distilled water. So how to measure the baricity of that drug? If you add the 3 ml of distilled water in 2 ml of bupivacaine plain, then 0.2% of the solution will give you a baricity of 0.99931. And if you warm the solution plain, this isobaric drug, at the 37 degree, it will again have that hypobaricity of 0.99931. If you add the 4 ml of distilled water to 1 ml of bupivacaine, then again the baricity will be decreased and it will just go down to 0.99726. The main advantage of hypobaric drugs are its early ambulation and discharge. So what additives we use for the local anesthesia, that is fentanyl, dexmed, ketamine, clonidine. Rinsing a 5 ml of how we use the dexmedetomidine while adding to the local anesthesia. So the rough calculation is when you rinse the 5 ml series with dexame, it is approximately going to add a 5 microgram of dexame. And the 1 ml of isobaric solution of the bupivacaine will anesthetize the 2-3 segment above and 2-3 segment below the site of injection. So if you give 2 to 2.5 ml of block, it can block from T2 level to T5 to L5 to S1 if the spinal is given at the T10 position. How much volume we use for the segmental spinal? As low as possible. So 1.5 ml or the less is sufficient for the T7 and T10 for the upper abdomen surgery. With some additive volume can be a 2 to 2.5 ml. The anesthesia will last for 90 to 120 minutes. Then you can use the combination of hyperbaric drug and isobaric drug. That should be used in different syringes. So for the breast surgery and superficial thoracic surgery, you can give the drug at the mid-thoracic level, like T4, T5 and T6. So isobaric levoanavin with 1.2 ml of 1.2 ml to 1.5 ml sufficient to block the segment below T6, C7 to T7 to T8. And the block will last for around 70 to 90 minutes. Mostly the fibroadenoma breast, a large fibroadenoma, even the MRM we can conduct under this segmental spinal in 1.2 ml. The surgeon should be little fast. So in this case, we just measure the block with the help of epidural coring scale for the arm movements. So we ask the patient for the hand grip, that we ask him to scratch my fingers hard and stop pulling them. If he is not able to just squash your finger hard, then the block level is C8 to T1. Then we ask the patient for wrist flexion test. Like we just bend your wrist and you don't let me strain. So if he is not able to do the wrist flexion test, then the block level is CA to C7. Then if we ask the patient to bend your elbow, don't let me straighten it. He is not able to do the elbow flexion against resistance, then level is C6 to C5 to C6. So USG is definitely useful in the segmental spinal. The drawback is learning curve with the USG and the availability is the problem. Otherwise, it can be used in the obese elderly patient with the spinal deformities. It enhances the safety and success rate. It can be used in the patient with the challenging anatomy, confirms the correct intervertebral level. Depth up to the ligament flavum could be measured, and the counting up method can be used to measure the exact level of the segmental spinal. So what are the indication of the segmental spinal? So it can be used in a daycare procedure when you want to discharge the patient on the same day. It can be used in the intra-abdominal surgery, upper abdominal, open or lap. Then breast or superficial thoracic surgery are definitely possible. Awake thoracoscopic surgery like bullectomy, thymectomy, lung volume surgery, where the patient is very frail and he is not a suitable candidate for the general anesthesia and ventilation. That time you can definitely use a segmental spinal. Then if the patient is not able to make the position, like he is just prone and not able to make the position, that time you can use the segmental spinal in the lateral position, as well as for the spine and musculoskeletal surgeries. So what are the contraindication to segmental? That are same as spinal anesthesia: patient refusal, coagulopathy, local infection, sepsis, aortic stenosis, and mitral stenosis. So complication, definitely a direct needle trauma, infection abscess if you don't apply your aseptic precaution, vertebral canal hematoma, spinal cord ischemia, and arachnoiditis. One main problem with the segmental spinal is it has at the thoracic level there is Adam Kivas spinal artery at the mid thoracic level. This is area which is very vulnerable for infraction. But your aspiration of the CSF and confirmation, it will prevent injecting this local anesthetic into Adam Kivas spinal artery. So confirmation is important before giving a segmental spinal. Then if you want to give the segmental spinal little higher up, like at a cervicothoracic area, there is a definitely risk of the spontaneous epidural hematoma. Then hypotension, bradycardia, nausea and vomiting related to hypotension. Thank you so much, sir.